Okay, I'm going to get started just to be respectful of everybody's time. Hello, my name is Tommy Fry. I am the president of Student Government Organization. I'll be introducing this virtual population health spotlight series with Dr. Maybank. I'm just going to give a brief introduction to Dr. Maybank and then let her do her thing and bow us all. Dr. Maybank currently serves as the inaugural Chief Health Equity Officer and Group Vice President of the American Medical Association, where she focuses on embedding health equity across the work of the AMA and leading the Center for Health Equity. Prior to joining the AMA, Dr. Maybank served as the founding Deputy Commissioner for the Center for Health Equity at the NYC Department of Health and Mental Hygiene. Aimed at strengthening equity efforts and transforming organizational culture, the center became a model for success recognized by NYC leadership, the CDC, and the World Health Organization. She was instrumental in infusing equity at the neighborhood level and advancing the department's place-based approach to addressing health equities. She also set precedents with the groundbreaking work at the Office of Minority Health in the Suffolk County Department of Health Services while serving as the founding director. Dr. Maybank has taught medical and public health students on topics related to health inequities, public health leadership and management, physician advocacy, and community organizing in health. In 2012, along with a group of Black women physician leaders, Dr. Maybank co-founded We Are Doc McStuffins, a movement inspired by the Disney Junior character Doc McStuffins, serving to shine a light on the critical importance of diversity in medicine. She's a highly sought-after health expert in the media, appearing on national and influential media outlets such as NPR, MSNBC, News One, Roland Martin, The Lancet, and the Journal of the American Medical Association, to name a few. More recently, due to her leadership in the COVID response efforts, she has been interviewed by Oprah Winfrey and authored the New York Times op-ed, The Pandemic's Missing Data, to bring more awareness to the structural inequities in the United States. She moderates the AMA bi-weekly web series, Prioritizing Equity, that elevates the voices and stories of physicians centering equity in COVID-19 response efforts. Dr. Maybank holds a BA from Johns Hopkins University, an MD from Temple University School of Medicine, and an MPH from Columbia University Mailman School of Public Health. She's a pediatrician and preventive medicine / public health physician. And now, after all that, I'm just going to let Dr. Maybank take it away.
All right, thanks, Tommy. I appreciate that, and thanks for the invitation. And it's funny how no matter how hard people try, it's really hard not to smile when somebody says Doc McStuffins in the introduction. But I really value the opportunity to speak with you all today, and thanks for the invitation. I've been thinking a lot about this work for a very long time, but especially in this new year and in 2021, with the transition to a new administration that has now explicitly focused on addressing and confronting injustice, and specifically and explicitly saying and talking about racial injustice and structural racism, which is a new day for this country, for the highest level of government to even utter those words from our steps at the Capitol. And I think it presents a tremendous opportunity for many of us, who have been doing this work for a long time, many before I even came along, and those who are currently doing this work. It's a door that is absolutely open, that we look forward to, but also it represents a door that also could close very rapidly too. And I think we're all kind of aware of the fluctuations that can happen in the political environment. And that if you don't capitalize while these doors are open, and this is what I've learned from working in government for so long up until now, if we don't capitalize on those opportunities, those doors can shut and the structures aren't there, the culture hasn't shifted, and we don't have as much progress as we want. And so I'm going to speak more to that at this point in time, because I think for you all are, budding leaders in this space of health, hopefully health justice as well, more specifically, though I feel if you're even in health, health justice and equity is part of your strategy as well. But I think it's really critical to think about how are we going to show up as leaders in this space to do this work moving forward. And that's what we really need is great and excellent leader. And we need more of them. We've had great leadership, but we need more leaders standing at the top or sides or around all folks to really talk about this. I first start and honor the indigenous people whose land that we all rest upon in this country, honor their legacy, their thriving, and their survival to this day, and all the contributions that they have had, and the trauma that they have experienced for the production of capitalism in this country. And then also honor and recognize all of those um, ancestors for me directly and indirectly who were forced to this land for, again, the sake of capitalism, who were sacrificed and sacrificed. This photo, I believe, came out now in 2019. This is a group of med students from Tulane down south, and they visited Whitney Plantation that was close to where their school is, and just really recognizing that they are there and present for all those who stood before them. And that's how I think about and consider my leadership in this work. And I think we can never forget the historical context of where all the injustice has come from. That's an important part of the leadership and narrative of doing this work. So I've been at the center now for health equity. Well, we started the Center for Health Equity. It's now around for about a year and a half. It was a mandate from the American Medical Association. So for those who don't know, American Medical Association is the oldest and considered one of the more powerful and influential health physician organizations within this country. It was founded in 1847. And it has 100 now, actually it has now 270,000 members, about a fifth of the physician population across the country that are part of the membership. But AMA is very influential in the advocacy and policy space, and they're influential in very much in the healthcare delivery space. And so my role is to really work and find ways, working with staff and really facilitating a process to embed equity and justice across all aspects in the entire enterprise of the American Medical Association. Clearly, I cannot do that by myself. And even if I have a team, that's not enough to do this work. And I think this is an important part of leadership and accountability and commitment to what does it really mean to do this work? Do I have the money and the staff to do this work? Do we have the buy-in and the leadership and the commitment? And do we have the accountability to do this work? All of those are important contexts to starting a Center for Health Equity and leading equity work, whether in any institution, honestly. And so we are working towards, making sure we're embedding equity, working with people in ways that we haven't before. So building those alliances and sharing power, ensuring equitable opportunities and innovation. Innovation is a highly exclusive space, predominantly white men, and very exclusionary. Pushing upstream to address all determinants of health. So, lots of conversation around social drivers, social needs, social determinants, structural determinants, but there's also the political determinants as well and other determinants that exist. And we're looking to create pathways for truth, reconciliation, and healing and transformation for AMA's past. And I'll talk a little bit more about each one of them, because oftentimes people ask me, so what is the work of a center? But before I can talk about that, I have to kind of talk about, where are our values at and kind of what are the principles in which we operate by. And one of the very important ones, because I think this is a conversation lots in academia around diversity and inclusion and equity work. And the reality is that, diversity and inclusion are important. They're important values. There are strategies that you can employ to ensure diversity and inclusion, but they alone are not enough to reach equity and to reach justice. Equity, a shifting of resources so that there's an equitable distribution of that. And then justice, saying that we're going to remove those structures and center those voices that are most marginalized. And all of these conversations are really rooted in who has power, who does not have power, who can make decisions, who has money, all of that. And that's where our conversations need to start leaning towards now, and talking about the structures of power and the systems of power, that being structural racism, but there are many other systems of power as well. So there's white supremacy and patriarchy that influence how people are treated and valued across this entire country. And that's where the conversations really need to start leaning towards and understanding how those isms that exist are impacting the health of people. And we have to be courageous enough to talk about the isms and not be afraid to mention or say white supremacy and patriarchy. that we know very much exists in this country. It's great that we have now gotten to the point to talk about racism more and more. And I think the generation that I'm speaking to on the phone or through this conversation, you all are more likely to talk about structures and structural racism. But the reality is that you're not going to encounter that when you go out into the community or out into your professionalized spaces and where you're going to be working. Many people are not comfortable with saying those words or talking about them or to even have an analysis and be able to talk about them in the first place. So our own personal grounding and our ability to communicate around these issues and through these issues is going to be really important in how we teach and engage with others and bring them along. And so COVID really, so this I got from a slide deck from somebody else before the new year. And there was lots of talk about, telehealth and medicine. And for years, that folks had been trying to advocate for the country to really take them on a little bit more seriously, but the movement was slow. And then COVID comes around and here you go, everything is tele everything to, or virtual or whatever the environment is. And so now we've gotten more comfortable. And I would say that COVID has also provided this opportunity, and really because of the public murder of George Floyd and clearly he is not the first person who has died at the hands of law enforcement in our country and for since the beginning of time in this country. However, it did spark some level of movement, during the summer that many of you are aware of. And so now it's provided this time to now talk about racism. There have been many declarations across the country from public health departments and healthcare institutions that this is the direction we're going to go. And I think the commitment and the hard part is what are they going to demonstrate and what are institutions going to really demonstrate beyond the performance of it, that they're actually moving in this direction. And also critical is just understanding that, and racism could be, replaced with a lot of the isms and a lot of the systems of power and oppression, but understanding and folks, tend to not make those connections that it impacts the body, the actual body. And so the embodiment process that Nancy Krieger talks about often is extremely important in understanding the impacts of these systems on individuals and populations, from changing the ways that genes are expressed, as well as increasing cortisol and stress levels and stress hormones in the body, which cause prolonged inflammation, all leading to inequities across communities in this country. And so if we go and we're looking to lead this work, we have to really look at ourselves. And I think for many of you, this is probably obvious. However, this is one of those other phrases that I think is very important. I love this quote. However, there tends to be a lot of lip service to it as well. And how do we hold ourselves accountable to what this is saying? What does that accountability look like? And how do we hold others accountable to it as well? I think it becomes the important part of the conversation. So we at the American Medical Association, and I'm going to talk about the institution, what can you do at your own organization and what organizations can be doing. And this is based on work that I did in Long Island and Suffolk County, but more so at the work that I did in New York City Department of Health when I started the center there. And so now it's just bringing it to the national level. And the reality is that you can't do equity work on the outside of your organization. Like you can work with community, and we hear that all the time, and I think this is absolutely critical, is that you do need to be proximate to community and you need to be proximate to people who are experiencing injustice. And many of you may have experienced injustice yourselves. So, you have a context to it, you have a lived context to it, but not everybody has. And so you need to be proximate to it. And that's important. However, we have to look inside of our organization. So the employees that are there, the staff, the teams, faculty, students, all of us that are inside institutions, what are we doing to help involve our own understanding and appreciation and analysis around where inequity arises within the context of institutions? And there are many areas within institutions. These are just the ones that are very important for AMA that are on the left-hand side, but there are many areas that are important for all institutions that you need to dig in a little bit more deeply to find out what's happening. Lots of people focus on workforce equity, which is absolutely critical, but a lot of folks don't focus on the leadership aspects or the communication or what's happening with data and metrics. And not just for the research that you're doing on the outside, which is important, but also how are you collecting data and what are you understanding about your work environment on the inside? Who are you giving your money to? Is it predominantly women and minority owned businesses, or, is that money distribution equitable or not? And so all this is really important to informing policy programs, research, and ultimately culture. It's the culture of the organization that really drives a lot of what happens at the organization. And so this is our theory of change to become a multicultural, anti-racist organization. And we're using a model, a best practice from Race Forward, which is the largest racial justice organization in the country, and the Government Alliance on Race and Equity. Their tool around normalize, organize, and operationalize. Normalizing, which I mentioned before, is about building the shared analysis and having the space within your organization to even talk about these issues. So that is where like training usually falls into place. But training is never enough, as many of you probably already know, but it is important. And it's important that you have race explicit training and not racial color blind training as well in doing this. And at the AMA, and when I came from the New York City Department of Health, we lead with race and racism, and we have a race and approach, understanding that there are intersections and multiple layers of oppression that exist and compound themselves. We also, in this model, is organizing. So who are your internal champions within your organization? What is the infrastructure to make sure that folks are engaged and know this work is happening? And then what are the tools that people need in their hands? That's to operationalize. How are we measuring ourselves? That's where the accountability part becomes really important. What are the data and metrics that we're using? And ultimately, I think within an institution, oftentimes they tend to start going through doing this work and they don't focus on the trauma-informed supports that are necessary. So in other words, not creating psychological safety for people as this work moves forward. Everybody is at their different level of readiness to do this. So conflict is naturally going to arise. There's already conflict usually existing already, but conflict is going to arise. And so a container space needs to be created to support teams and people as we move through this work. Trauma-informed supports, and many public health folks know, are important very much to the external community and the external environment of your institutions. We talk about it a lot, but it's also important to the internal environment of which you're working. Um, Also for our teams, these are critical questions. This comes from the Racial Equity Toolkit, and our teams are going to get trained on this very soon. And this is, how do we ensure for us that our efforts and innovation do not discriminate, exacerbate inequities, or deny? And I think what's really important about this toolkit and the questions that tend to stand out is understanding who benefits and who will be burdened by the decisions we make, and what are the strategies for mitigating unintended consequences. So the AMA, for the very first time, very first time, passed policies this November that explicitly mention the word racism. And on one hand, it's a tremendous accomplishment and achievement for AMA and medicine as a whole. I've spent most of my career in public health, and at the New York City Department of Health, I had Dr. Bassett, who was my leader, and we led with racism. It wasn't foreign to us to be able to speak that language or to talk about this. And in public health, I would say it's probably a lot more advanced than it is on the healthcare side. I'm now kind of squarely rooted in healthcare and have learned a lot about the divide between public health and healthcare and the importance of those coming together. And I think many of us have during this time of COVID, but also just understanding the critical nature and the lack of really talking about racism as a public health threat and anti-racism overall. So now we're in this time where, our board of trustees did make this pledge over the summer, and then really held greater accountability by the membership passing these policies. And so we now can do work and action towards this. I actually think the third one is the most significant, is supporting the elimination of race as a proxy for ancestry, genetics, biology, and medical education, research, and clinical practice. And so I think these will go a long way, and we have a lot of opportunity to build on them. Many of you probably already know and have a sense of racism as a system, and the work that we do at an institutional level has to be around the anti-racism praxis. And understanding that we have been in this country or under this system for a very long time, and we've only been for a very short time, a legally free country, as represented by the green in this particular slide, and for the most part have had legal oppression for the majority of the life of this country. And I'm not saying that in this legally free period that people are not oppressed and that policies don't and structures don't oppress people, because they absolutely do. But just to know that, this is, I was talking to someone the other day, and I feel we're just still at the very, very beginning of this journey to justice and liberation for our people in this country. We're at the very beginning of it. Also, I think what's going to be critical in terms of leadership and how we show up in this space of equity is how we're talking about the larger systems and the other producers and other root causes that are actually it's a global context in terms of colonization, but how those set up the systems of supremacism and capitalism, and their connections the whole way to the body, again, as I mentioned earlier, to inflammation, which is on the in the middle, almost towards the right middle of the slide. And I highly recommend, for those who are interested in understanding, I think, medical culture and medicine's contributions to inequities, and really how medicine, I think, set up the foundation for scientific racism, and structured it. I think the great book to read is Harriet Washington's book, Medical Apartheid, still to this day. So part of this work is also challenging dominant and malignant narratives that really undermine equity. And many of you have heard these, are probably familiar with them. But if we don't challenge them, we can't undo them. And so, definitely race is not a biological construct, but there's still a lot of belief around that. And even in the framing of many things around COVID, when you heard more about, Blacks and brown people having higher rates of COVID, not elevating the realities of being essential workers or other realities in the historical context of injustice for Black and brown communities, it comes off as if the communities are to blame for what is happening to them, which means it's connected in their folks' mind that there's some biological basis of it, and that's just not true, that I'm sure many of you understand and know today. Our individualism in this society also really undermines our ability to work collectively with one another, and to advance equity as well. The other and belonging as well, picking ourselves up by our bootstraps, the myth of meritocracy. I think many of us are very clear that there are people who work very, very, very hard, who are not as well resourced, and will work as hard as another person and still not get to the same levels of wealth. It plays out in our data. If you gain, I lose, the zero-sum game, and the myth of that as well. And then finally, the myth of the hierarchy of human value based on skin color, with white being supreme. All of these are narratives and value targets that we have to make sure that we get to. We can talk about the technical pieces of the work, and I mentioned some of those earlier that are very important. But if we can't even challenge these and work through and deconstruct these, it's very hard to become a society and an institution that can fully embody what equity looks like. And this takes courage at this point in time, because not everybody's ready to talk about those values. And Dr. Kamara Jones talks about this a lot. It's about unearthing our bias and blind spots, but we have to go further than that. Even when we look at like data and how we're collecting data and doing research, there's lots of data now. I'm not saying that there could be more and more understanding that is very descriptive and describes inequities. We have many reports for several years now, more than several years. And I think what we need to get towards more, and I know this is building even at some places within Drexel as well, is really understanding the impact of these isms and the systems and how they are influencing health outcomes. That is what we're going to need more and more data around, and then what to do about it in the meantime. And so again, going to research, and I think I mentioned this, there's a great article in, this is Health Affairs, by Rhea Boyd and Edwin Lindo, Lachelle Weeks, and Monica McLemore, all great scholars, and colleagues as well, on racism and a new standard for publishing on racial health inequities. And Rachel Hardman also has written several good pieces on this as well. But this is where we really have to challenge ourselves and how we think and challenge our critical consciousness to how we come to this work. And then also push one another to do the same and other colleagues. Another set of work that we're doing, and I just bring up innovation in this because oftentimes, especially in the healthcare space, but I hear it in public health from being there, this context of innovation, usually rooted in some technology of some sort, and usually, again, pretty exclusive. And there are a lot of opportunities that are good. There are a lot of, we know for sure, there's a lot of harm that can happen as it relates to technologies. But if we have the right people or different people who are provided and afforded the opportunity to be able to have their ideas developed and evolved and become, in quotes, innovation, and people work more collectively and collaboratively, we can potentially have some better and really good solutions to advance and address health equity as well. So another pillar of that we're working is pushing upstream. So this is one of the big opportunities and gaps that I've noticed from being in healthcare now is public health. Again, there's this divide, and for the most part, the narrative in this country is really connected to the healthcare system about health. So if you don't have health services, which is important, but not enough, but if you don't have that, then that's why you don't have good health. And we know, all of you know, that that is not really the case. But healthcare has not fully embraced that. And so my desire and push, just because I've been in public health for a long time, is to find ways to connect those dots a little bit better and to help inform, especially the healthcare environment and community, more about what does public health even mean. And we're fortunate in the AMA mission, it does have promote the art and science of medicine and the betterment of public health. So I've been leveraging that as much as I could. But most of health is really on the left, healthcare rather, is on the left-hand side, and they're addressing social needs. So that is it's a difference. There's movement to understand that there are social risk factors and then there's social needs for patients. But there is more that that healthcare entity could do to consider community health implications as well as larger public health implications. And as most of you know, that's not a singular or siloed opportunity. That's something you have to do in partnership with others. But there have to be systems that are set up to do that. And there has to be much more communication between healthcare and public health in order to even get or even have the opportunity to reimagine what can a health system in this country look like that's inclusive of healthcare and public health. And for those who don't know, this past fall, I had the opportunity to sit on the task force for the 10 essential public health services. All of you all, if you're public health folks, will absolutely be tested on this at some point in time. But they were revised, and they were revised to really fully center equity, not only as an overarching goal, but throughout the whole thing. There's a lot that we're doing in terms of Health Equity Education Center and educating physicians and other health professions. We just launched, the Health Equity Education Center to do that. We know we have to provide physicians more hands-on. So we have a medical justice and advocacy fellowship that we are getting ready to launch to have folks better understand those political determinants of health. This is written by Daniel Dawes, who took over the Satcher Leadership Health Institute from, was passed down to him, I would say, from former Surgeon General David Satcher. So we're working on that as well. And we're doing a lot in order to kind of engage in the Latinx community. And I will say this is, again, one of those moments for AMA where we were behind on it and now we're kind of catching up. But this is the area right here, right the wrongs of the past, that I really want to really dig into. And, the reality is that no institution, I can't read the top of my slide because the thing that is there, but we can't, no institution really and talk about a commitment to anti-racism and our equity without assessing their institution's own history and present practices. And the reality is that most of our institutions that are historically white have had some or committed some type of harm, oftentimes to the neighborhoods that they're served or somehow to their employees as well. AMA is well known to having a history of exclusion. We didn't formally admit Black physicians until the civil rights legislation was passed. So we actually had exclusion across the country in different places. There was a report that we issued in 1910 that recommended that 5 of the 7 Black med schools get shut down, and they actually did. And that has tremendous impact even to this day on the lack of diversity in the medical school and physician population across this country. And we were silent in the civil rights conversation and policy around desegregating hospitals. And so, there's a lot that AMA has done that we have to own, and that's only some of it. We have to own, we have to be able to name, and then we have to figure out what we're going to do. We did issue an apology in 2008, and our the apology was by Ron Davis, who was president at that time, and it was to the National Medical Association that was created because Black physicians were excluded from the AMA. And so we have the power to right the wrongs, as he says, and it's our first step forward for healing and reconciliation. But it's 2008. AMA has now been around for 175 years. So I in no way sit here and say that we did this early and that we did the right thing early. We're on the path and we've started, but there is still so much for us to do to reconcile all of that path. Um, and really formally go through a truth, reconciliation, and healing process. I think one of the more popular truth and reconciliation events that folks know about or aware of is the transition from apartheid in South Africa. We have not, and other countries have utilized it as well. They have in Canada for Indigenous people as well. And there are over, I think, 200 examples across the world, rather. Here in this country, we really haven't fully embraced it yet. It has been talk and was conversation prior to this administration starting, and we'll see what happens moving forward. But I think that this is going to be where the front line of health equity is, where we're going to be talking about what are we doing to honor the people who have experienced injustice at our own hands as institutions, and how do we I think my question to you is always, and the opportunity is, how do you show up as leaders in this, knowing this moving forward? Another example for us as the AMA is our former president, J. Marion Sims. There was a statue in New York City in Central Park. It was removed in, I want to say, 2018. And basically Sims, and I didn't even know he was former president until I came to the AMA, but Sims would do procedures on women that were enslaved without anesthesia, vaginal procedures, in order to kind of create excellence for the sake of for GYN. And so he created the speculum that we still use to this day. And so we have to, honor and again recognize this complicated history that's happening in many different ways. And this is just a photo of that day when the statue was taken down. I was still working in the city, and I was there as a city official. In the middle is actually Harriet Washington. It was her book and her truth telling which made this story really visible to many folks, which is another part of how inequities can happen and just continue to happen, is the intentionality to make invisible stories and history of people. And on the right hand side is a woman who was running by, and I don't know this woman, that's me. Hopefully that's obvious, but I didn't know the woman. And she saw the statue coming down and she just started to cry and say, can I have a hug? Because I run by this every day and I feel traumatized by it. And the neighborhood and the community had been asking for the statue to come down for years. And so I think this is an important context to equity, is one, clearly the literal dismantling of structures that we know harm people, and the centering of people's voices to do this. The community, again, had been advocating for that to come down for years. And so we say as institutions, we value partnership, we value community engagement. We have models about community engagement, building measures of community engagement. But are we really accountable to community engagement? Are we really valuing those voices? Are we really valuing their power to make decisions and their understanding of their own day-to-day lives? Those are the questions we have to ask ourselves. And from being in several institutions, oftentimes it can be very performative. I think there's always great intention, but equity is not just about intention, it's about the impact of the decisions that we're making. And that's what we have to focus on. And so whose work this is this as I close out? It's all of our work. But I think, what's important and critical. And David Satcher talks about this more and more, I think, as at this point of his life, is that we need leaders who care. And care seems so obvious, but just really, truly care about the stories and lives of people, not just the numbers and the data, but what do those data really represent in terms of the voices and the stories? How does it connect to really our hearts and our spirits to do this work? Oftentimes this work gets left up to the mindset, but movement doesn't happen from doing this work long enough. What I have found, what has compelled people to change and to do things differently is usually by some story of being or relationship, from being proximate to somebody, a story, paying attention, listening to stories, and hearing about, unfortunately, kind of the harm and the experience of others. It's those stories that are really important. Numbers do not always move people towards change, but stories absolutely can. Being curious enough to make sure and that we're always challenging and always challenging kind of our thinking and our theory around why something is happening and why something is. And then the courageousness, I think, to speak up and to hold others and ourselves accountable, to me, is absolutely paramount. That is where I see, folks crumble. People care, but I feel like if you care, then you should be courageous at the same time. But oftentimes, it does stop at that point, and the courage to say something when you see something wrong, I have seen over and over again where people don't, they sit in silence and they don't say anything, and I just don't understand the benefit of that. I understand the feeling of the risk of it, but oftentimes that's a perception than a reality. And if you build up the skill set to be able to say and name injustice within your institution and within your community, the family, whomever, it becomes easier and easier over time to do it in a way that's still loving, and but direct at the same time. I also just want to speak towards like whose work is this in terms of just race and ethnicity, because I hear a lot of conversation around allies, and I believe in the importance of working with one another and working in solidarity with one another. What I find with the word ally is that becomes a little bit passive for folks, and there's like a waiting. There's a waiting for somebody to do something in order for that person to feel like it's okay to do something. And I don't think that's quite right. I think we all have this responsibility. We're all in this society, and we all have a responsibility to figure out how do we step up and how do we show up in this space and in this work. And I go back to this definition of racism. And in this definition, it is inclusive of whites and it's inclusive of people of color. And I just feel that it's all of our, and so that means we're all part of this system. Clearly, I'm not advantaged by this system at all, and the people of color are not advantaged. And so I think that there's a stronger role that many leaders and institutions can have without having to put the burden on the Black and brown folks within the institutions to figure out what those solutions are. We are all part of this, and we all have to figure it out. And I believe more so in considering the value of being accomplice or an alliance or a coalition. Again, just using your voices as an article that the one was mentioned this morning. Myself, Dr. Kamara Jones, and Dr. Uche Blackstock and Joya Career Perry wrote a piece in the fall on Dr. Susan Moore, who passed away from COVID. And she is one of the only cases that we really have somebody's experience videotaped of the healthcare system and the realities and perceptions around the experience of racism. And we wanted to make sure that we elevated her name. But for many of you who are in health, whether you're NPH or whatever you are in health, you're a credible voice. And I highly encourage you to use that voice to speak out in many different ways. There's local media, whether where you're from or even in Philadelphia itself. There are many people who are doing work like write about it, and not just in our highly valued peer reviewed journals. I think that's important. But there are also just more public facing spaces that people are looking for health professionals to speak about. And then this is I kind of mentioned this already, but the importance of being willing to be uncomfortable. as a leader, and also being proximate to the challenge. And this slide here, accountability to me is I think the number one, um, I think opportunity that I put forward to folks on my team and to leadership. Without accountability, this work to commitment, and the commitment does totally falls on its face, truthfully. And we have to be able to hold people accountable to do what they say they're going to do. And we have to be able to hold ourselves accountable as well. This is a critical piece of doing anti-racism work in institutions and in this country. And I look at, um, today was announced, the White House announced their Health Equity Task Force. And as many of you know, the White House issued an executive order on equity and racial equity, and for it to be embedded across all levels of government at the federal level. And, I think many times, we're waiting to see, do they really mean that? Are they really committed to it? How is that going to show up? And so I looked at the list, and I will say, like, I'm completely pleased at the list, because they absolutely centered voices of those who are most marginalized in this country, and people, and maybe some leaders connected to those voices, but they really focused on who are the marginalized communities within and people within this country, and how do we hear what's happening with them, and hear with them consistently. And I was just really impressed by that. And to me, that's how we have to show up in doing this work and be accountable to doing this work. And just lastly, just remembering, again, I mentioned about stories, and these are real people's lives. We do a lot in the academic space and in the healthcare space, public health institutional space, um, around, data and charts and graphs. But we can never forget and should never forget about the violence that this places upon the body, the violence of structural racism and white supremacy. Um, and that's what our focus and our lens should really be all the time, of what we're fighting. Our charts and our graphs are just to help us better understand that reality. And lastly, of course, is to not be silent, and to use your voice again. Thank you.
Thank you so much, Dr. Maybank. Definitely a lot of food for thought, I think, for all of us. There are a lot of great questions in the Q&A. Please keep them coming. I know we only have a few minutes, so I'm going to do my best to get through as many as I can. If your question isn't asked, it's nothing personal. I'm just trying to ask questions I think will bring about the most well-rounded, I guess, discussion. One question recently from someone says, what do you believe are actions that academic public health can take to actively center equity?
Yeah, I think some of the things that I mentioned in the deck are things that academic medicine can do. I think you start with one, naming that this is going to be a priority, and this is what, we're going to take an anti-racist approach. And we're going to name that, and the whole institution knows that, and leadership is committed to that. So I mean, like, the highest level of leadership. And then, because this work can't be done alone, shouldn't be done alone, early steps are just starting, a committee that leadership is engaging with, to start thinking through planning of what should happen. And that committee should not only be made of top level or senior management, but it should be made of students and different folks from different levels of the institution to think through planning. And then now, honestly, there are lots of consultants out there that can help support an institution going through this process. But I think critical is making sure it is named, that it is started, that leadership has accountability, and declaring it and starting the committee. There's a Health Affairs, which is a policy peer-reviewed journal. Last 2 weeks ago, the editor-in-chief wrote a blog and issued an announcement that they, one, just kind of honoring, recognizing that they have so far to go as a journal, and saying this is what they're going to do. None of this work is perfect. There is no map that's written out to do this work, but you have to kind of, a lot of folks are making the road as they walk, but there are folks to kind of, consult with and share with and find out ideas. But the point is, of the health of Sorry about that. The point is of the Health Affairs Journal is that they have started the work and they have publicly announced, and so that allows for accountability.
Yeah. Another question I see here is, I'm going to summarize a little bit, but is it possible to achieve equity without some form of reparations? I think about the equity of racism, segregation, racial terror, health inequities, etc., and wonder if naming and moving forward in that acknowledgement is enough.
Is it equity? No, probably not. I mean, I think there has to be some form within this country. This is not AMA policy. This is Aletha Maybank. Sorry, this is Aletha Maybank. We have not have any policy on AMA on this. However, I do feel that some form of reparations is going to be critical to achieving equity within this country and within our institutions. Naming it is not enough at all. The action behind it is what's absolutely critical. So when I mentioned the truth, reconciliation, and healing, naming it is not enough. Sorry. Many folks will kind of give credit that I'm bringing it up. That's not enough if AMA doesn't do anything towards it.
So I'm just going through, trying to find questions that you haven't answered and other answers. Here's one you sort of, I think, mentioned, but I think it's still a question worth asking. In public health, we are familiar with the concept of health in all policies. How can this be expanded to a concept of health equity in all policies or anti-racism in all policies?
Yeah, I think that's an interesting point. When I was at New York City Department of Health, we tried to do health in all policies. So while public health is familiar with it, this is the reality. It's not embraced in this country. So I feel like, yes, we should reframe to equity in all policies and health in all policies. We can say health equity as well, but I feel it's equity in all policies because it's not just health policies, but it's all policies, right? And that will help improve health. But we haven't embraced that in this country. Other countries, we tried to do some of that work and planning at the local level in New York City, working with other city agencies outside of health. And we were able to get to the table, but we didn't have buy-in around this because of folks' narratives around what creates health. It's not, education, transportation, and all of those things in many places across the country. New York has evolved now and is definitely more so embracing it, but not the context of health in all policies. Because what's important about that is the governance structure. That's what makes it health in all policies. There's the framework of it, but the actual action behind it, I am so sorry. The actual action behind it is what is the governance you're setting up so that all these folks are at the table together doing shared decision making, setting up shared targets. And a lot of times in this country, that's politically just not a fun thing for many people to consider. So only California has embraced that model, and New York State a little bit. But other than that, we have to get people to just buy into the concept. So we'll see what happens with the federal administration. I've heard it elevated several times that this was going to be a way to go.
Another question I see here I think is helpful for our professionals at any level. Do you have any recommendations to help an organization be trauma informed in their anti-racist work?
Yeah, so there's not a lot on this out there, in all honesty, and we're still learning how to do it. There are a few specialists around the country. Then this is something this is going to sound bad, but kind of Google and just start kind of researching about it. There are folks who, at the San Francisco Department of Health, who have embedded a trauma-informed, my goodness, have embedded a trauma-informed approach to their health department work. So that's a model to kind of read up about. There are a lot of reproductive justice leaders as well who have implemented trauma-informed approaches to their work as well. But I think um, there's a lot that still has to be done and communicated and educated around. I think the foundation for trauma-informed approaches is a lot of the work around ACEs, the adverse childhood experiences, which many folks don't even know about either. Nadine Burke, who's the Surgeon General in California, is really kind of known as the pioneer in that space and really elevating the work of ACEs to say that these adverse childhood experiences that people have impact their long-term health physically and mentally, as well as socially. And so I think a lot of that work is important to become familiar with too, as we start to consider trauma-informed approaches. But I'll say we didn't do that in New York City. It's something that I realized coming from New York City, and looking at models like the Brigham's in Massachusetts and Boston. They have a trauma-informed approach to doing their internal work, and they have specialists on board. So we're actually working with them to help inform our process at the American Medical Association.
Before we go, I just want to ask, do you need a second to catch your breath and kind of just wait?
A little bit.
Okay, I'll wait a little bit. No problem.
Yeah, okay, let's try.
Alrighty, okay. Let me know, obviously, if I'm going too fast, please let me know. One question I see.
Talking a lot. That's what it is. Not just today, but just in general.
Right. How do institutionalized isms affect healthcare availability and affordability?
Yeah, so that's an area that we're now stepping into as well. So looking at within healthcare, quality and safety within an institution. So most healthcare institutions have systems of quality and safety. And there have been recommendations on what needs to be included in quality for years now, but oftentimes the equity part of it has been left out. And so what has happened in the work that we're starting to bring on now at the AMA is using quality and safety as a vehicle to embed equity within an organization, because the structures are already there. We know that all of the isms, the isms affect any institution in this country, and they're going to impact what's available and the quality of the care that's available. Our imperative, and there's a lot of data around that, our imperative is to start working towards doing something about it. So organizations like IHI, they have a Pursuing Health initiative in which they are working with healthcare institutions across the country to do exactly that. So working through an actual structural process of which they are identifying those parts within their healthcare systems that are creating the most troubles and inequities within their systems. But they're doing it through a quality and safety lens, which I think is absolutely critical. But they're on the healthcare side, I will say there is not a lot of work yet, again, on what people should do. I think that's the challenge right now. We're at the point of naming and saying that these things exist, but there are not enough tools yet for people to utilize to do something differently. And so I think there's just going to be a lot of learning at various institutions across the country. Evaluation is going to be extremely important of whatever those tools that are created, and then ultimately research to better understand the impact of the tools and the decisions that are being made.
I'll give you a second to catch. We have 5 minutes left, so we probably have time for 1 or 2 more questions, give or take. I'm trying to find a good one. Or they're all good. So I'm trying to find one that makes sense. Here's one. Basically, I'm going to summarize this question. What is a way to make anti-racist training in workplaces more effective and basically not backfire and have the opposite
effect? Yeah, that's a very important question. And that's the part where I was bringing up earlier, that there are a couple of things, like the culture has to have some level of readiness to do the trainings, which means the leadership has to kind of say to everyone that this is the direction we're going, right? So there has to be that environment that's set up from the leadership to do that. Then the culture needs to also be supported, not just by this fact that training will exist, but there usually needs to be some bringing together of people to talk about, all the considerations that could happen, when we start to bring training into the space, but also to consider what else needs to happen within the organization. So that whole kind of organizing part of it. So I talked about the normalizing, which is like the training and building shared analysis, but training alone will backfire because the culture and the environment is not ready to address people who now are like, and I don't want to say woke but I will say woke, but all of a sudden feel like they're woke. Either they're woke or they feel like they're woke, and then that just creates conflict and tension. And that goes back to my point earlier of the importance of having a space for psychological safety. There are so many factors that have to be considered when you do institutional change work. You have to consider, again, the leadership environment, the culture environment. Are the resources there to have enough people on board to be thinking about how to structure all this, that it's their full-time job to do this? That's the other thing that I recommend. There's consultants, but you need to have people hired full-time to do this. And it's not just the diversity and inclusion officer. I think, again, it has to be brought into equity and justice. And those folks need people. They need people on their teams to do this work and to do it well, and to help support people across. And people also need the tools. They need tools to challenge their mental model. So they need the training, they need to organize, and you need tools.
We have time for one more question, probably. This is just one that kind of near my heart because as a first year MPH student, but it could apply to anyone. Do you have any recommendations on how young public health professionals, renew MPH graduates, can begin to affect change within public health prior to a set career within the field? So I guess when you're starting out, what are ways that you can take on this kind of work?
Yeah, I mean, one, I think y'all are engaging in this way. So Tommy, you're leading, you're president, right? You're a leader in your organization. So uh, all the leaders can tend to remain leaders in that way. So that's a good way to step up. Um, but within the context of your institution, I mean, um, you have the ability to come together and be collective and look at what is not working within your institution. How are things not showing up? And then as that collective, you have the ability to present something to your leadership, and work with others to say, this is how we would like, opportunities to move forward within our space of Drexel. And are you going to get everything? No, but that's not the point. The point is like for you to kind of, I think, know that you have the power. You all are paying to go there. So you all have kind of the power to kind of come together and set up that opportunity to have those conversations with your leaders. That's how because it's building that muscle, because it's the same thing is needed in any institution that you're going to go to. It's figuring out how you're going to show up. I think there are other opportunities as it relates to advocacy, and y'all are in a different time than my generation is. Y'all have seen what it's like to organize and to march on streets, and to really show up in your power in that way. And so I would just say continue to do that work, and build that capacity, because that's what's going to be needed, I think, as strong public health leaders in our spaces moving forward. While our administration has changed, and for folks who are in equity and it feels more hopeful, let's be clear that administrations change again. Let's be clear, we're still in a white supremacist structure and in dominant culture, and that we always will have to continually fight and name and change and challenge narratives that exist. The important thing is not to get comfortable in this environment. Maybe we can breathe a little bit easier so that we can plan and have forward movement. But we need to continue to have forward movement with, I think, always the urgency of now. Folks will say this is a journey. Yes, we know it's a journey. It's been a journey. It will always be a journey. People will say it's a marathon. I'm like, yeah, it's a marathon, but there are moments where we have to sprint in that marathon. And I don't think this is a moment where we stop sprinting just because of where our administration is. So I think the more you are engaged within the context of your institution to change its structure, the more you're engaged and challenges within there for the good, but also how you're engaged in kind of political advocacy outside your organization and in your neighborhoods, I think is really important.
Well, that was a great, really inspiring way to end this. I want to thank you so much, Dr. Maybank. I want to thank everyone for watching and asking your questions. Sorry they weren't all answered. This talk will be posted onto Dornsife's YouTube page. I don't know exactly when, but after this is completed. And thank you so much again, Dr. Maybank, for your time, your wisdom,
Well,
and your
thank you.
experience in sharing that with us.
Thank you.